Hey everybody, welcome to another episode of Airing Addiction. I'm your host, Dr. Romas Buivydas, and we're here at New England Recovery Center in Westborough, Massachusetts. And we have a guest today who's going to shed some light on some topics that are tough for folks, especially family members trying to get their loved ones in, or just regular folks who want to get into treatment. And his name is David Nefussy. He is the Vice President of Business Development for Spectrum Health Systems. So David, welcome to Airing Addiction, and glad to have you, because this is valuable information for our viewers.
Thank you very much. I look forward to hopefully being able to provide some useful information for the clients.
I think you will, because you know your stuff. Tell me a little bit about your background, how you learned, and quote, this is about insurances, folks, how to talk to them, how to work with them, get them on your side so you can get the help or get the person you love the help they need.
I want to be 100% transparent. Before I worked for Spectrum, and now it's Spectrum just past 2 years, for the previous 27 years, I actually worked on what is called the payer side, which is a fancy term for saying I worked on the side where the insurance companies provide information. So I actually worked for a number of insurance payers, some national payers, one called private healthcare systems, and I went from there to a local payer in Massachusetts called Pilgrim Healthcare, which then became Harvard Pilgrim. And then from there, I worked at Beacon, Magellan, Pacificare, and then which became United Way of Health and Optum. So I've had a great deal of experience working on the provider side, doing a lot of contracting, provider relations activities, but really understanding the ins and outs. And one of the things that I hope to be able to do today with the people looking at this is to really be able to take the insight of how to work together with the insurance company, so it's truly a partnership, and it's not seen as an adversarial relationship.
Okay, because I can certainly say trying to get coverage authorizations for clients, I get to talk, we used to have to, I don't do it now, but our clinicians still have to talk to insurances to make sure that stuff is authorized, appropriately done so, and all of that. And yeah, frequently we would see the other side, the insurance people, as the enemy. They just don't want to help you. They want to keep you out from getting inside and getting help. And it's kind of nice that you came from the other side. So now you're seeing what clinicians go through, what family members go through. And that's why it's going to be an interesting episode, because it's going to tools of the trade of how to work with insurers about getting what you need for help. Accessibility.
Exactly. Yeah, I think that, again, what I've seen and what I've heard when I worked on the payer side is the challenges that there's always this myth, this belief that insurance is only as good as if you don't need to use it, and when you really need to use it, that's where the challenges come. And, I think that's really more of a fallacy. I really do want to believe, and maybe it's naive on my part, but, I think that the insurance companies really do want to try to work with you. It's just that dynamic of just trying to figure out how to do that. And I think that, some of the challenges that we have, particularly as it relates to substance abuse, which is our substance use, as we're having that discussion today, some of the issues or difficulties and challenges that people may have faced really have been alleviated by some regulatory requirements as well. So, in looking over some of the challenges that people had previously in accessing higher levels of care, which when I talk about higher levels of care, really I'm talking about accessing an inpatient detoxification.
So let's start with that.
Sure.
Okay, that's a good segue. To make sure that all our viewers understand, because we're using lingo that we use amongst ourselves, and what is a level of care?
Yeah, so that's a good question from a jargon standpoint. So a level of care is really what I would like to say is a setting for which a client will be accessing service. So the highest level of care is always going to fall on your inpatient. So as it relates to substance abuse, that would be the people who are getting a detoxification, which is really when one is cleansing the drug that's within one's system out of their system. The next level of care would consider residential, which is really the rehabilitative level, where one is getting a therapeutics discussion while a person still is remaining in an inpatient setting. And then from there, one would go to the various level of care, partial hospitalization is also known as an intensive outpatient. Also, for those who look at terms, also known as structured outpatient addiction provider, or SOAP, that's another fancy term, to where one then could go to what is known as outpatient with medication-assisted treatment or without. And then we have stuff such as peer services today, which would include like the recovery coaching and recovery navigators. And these are all various level of cares that clients potentially have access to with this major epidemic going on,
Right.
I think the full continuum of care is something that's very advantageous for most clients.
Okay. And all those care levels make up what we call a continuum of care.
Correct.
Across recovery. So let's clarify for everybody. Inpatient, that means you stay overnight.
Correct.
And you don't leave the premises except maybe for a walk or something like that with staff. And let's say, looking here at the Westboro campus, there are levels of care here that some people may have heard of, may not have heard of. So, inpatient detoxification, that's management of withdrawal, correct? And that's you're staying overnight. Mm-hmm. How long does that last typically?
And that can last, usually we say from 5 to 7 days, but it can depend upon usually the substance being used, so some people can have a shorter time period. I think one of the fallacies are, and one of the challenges that we have, and for those to your consumers out there, which would be probably educational for them, is there's really a myth out there that people believe by simply being detoxed, that usually is sufficient in being able to be successful completing treatment and maintaining sobriety. And I think what people don't understand is a detox is really the cleansing of the drugs in one's system.
Right.
There still is the underlying component that needs to be treated, which is really the therapeutic component, which could be at a residential or it could be simply as an outpatient. I think that one of the things that I think is really important for a consumer is not to always think that the highest level of care is always the most appropriate level of care for a client. Certain clients, if they're high-functioning individuals who may be needy of I'm going to use the term, and again, we can discuss it further, like an opioid detox, so they're using heroin, they would potentially be eligible for being treated strictly on an outpatient basis with medication-assisted treatment and not need a detox. With that being said, that doesn't mean they can't get that. And again, as I opened up these discussions, there's been some regulatory changes in our state and our Commonwealth that really allows clients to now access services at all levels of care that may have been previously denied by the payer or the insurance company.
Oh, okay. So that's pretty significant for Massachusetts then.
Correct.
So, we just put it together that detoxification is basically withdrawal management. That's just getting the person away from the issues of withdrawal. And then they could go, for instance, they can go to a clinical stabilization service, correct? A CSS sometimes?
Right. They have right. So it's very interesting when one uses that terminology. And again, coming from the payer side, one would see as a crisis stabilization, which you utilize, the CSS.
And it's post-detox.
Right, and that is a term that is actually used primarily with the Medicaid mass health population. For the purpose of a commercial payer, that is not a term that they would resonate with them or would be a benefit. It would be a residential. So commercial doesn't go to those various levels of care. The CSS, or crisis stabilization service, really resonates more so on the commercial side with the residential. They would be equated to the same benefit.
Okay, so to clarify again for our viewers, commercial insurance means Tufts, it could mean Blue Cross Blue Shield, Harvard Pilgrim,
Aetna, Cigna.
all of those.
Correct.
Whereas Mass Health is the Medicaid side.
Right, and what sometimes creates confusing as it relates to Mass Health, you could have a Mass Health product which is also operated by a regular insurance carrier. So Tufts is a really good example. So Tufts Health Plan, which is commercial insurance, also has what is known as Tufts Public Plan, which used to be known as Network Health, which is the public sector or the Mass Health portion of Tufts, where they have maybe some different benefits that may not be available to that of the commercial population.
So now, let's back to this CSS, clinical stabilization. You detox on your own at home, somehow. But I want to get into that clinical stabilization service program. Can I just walk in?
See, that's a very interesting component. See, one of the things that is unique, now that would not be something, and that's, again, this is where the consumer needs to really do some research and be educated it's on the way that facilities and who they choose to select to do their treatment. That would be something that would vary by facility. So most payers would allow a person, you would hope, to go to what's most medically appropriate. So use the example of a crisis stabilization or a CSS. Well, I'm going to go one step further. So if a person is a user of a substance, and I'm going to use the example of cocaine, which is not uncommon. A person who is use of cocaine would not trigger the higher level of care, which, as we stated earlier, which would be a detox or a medical detox. That does not trigger it.
Right.
A
So
person,
is there a detox for cocaine?
the answer is no. So the person would have to start, at, as you noted, at that second level of care, which is the CSS. That it would trigger for, and therefore that person would be able to go to such
Eligible
services.
there.
Correct. Where the issue comes in, and this is where the challenges within the insurance industry or the provider industry come into place, some providers will require that a person start off at the higher level of care and only will be allowed to go as a step down to the next level of care, versus some companies, and again, I'm going to plug obviously our organization, Spectrum and New England Recovery Center. We believe the person should go what is to the most appropriate level of care, which may be in the least restrictive setting, and in that scenario, a person could be what is known as a direct admit to that lower level of care. There are some, as I say, some providers out there that would never allow a person just to start off that level of care. They'd have to start at the detox.
So, okay, I use cocaine, I stopped using it at home, but I want some help. I think I need to be in a program because being at home, too much temptation to go around the neighborhood, I can pick up stuff very quickly. I want to be inpatient, right? Where do I go? How do I, and let's say I have Blue Cross Blue Shield, let's say that.
Okay, so one wants to access services. So, one would either look into a directory, they could call, there's multiple websites that have availability, or they get word of mouth, which is usually the most common. They would then contact our organization, our intake line would take them. What we would do is we would probably, at the onset, have probably somewhere between a 5 to 10 minute kind of discussion with the client, trying to understand what substance they're using, what might be the root cause, some preliminary information, the frequency of use. But you used a really good example, which is something that's very critical, and I think the population who may choose to utilize these services needs to totally understand. If a person is not using daily, is not a frequent user, and has the ability to go long periods of time, it might be binge using, they may not trigger any higher level of care. In a lot of cases, they might be able to receive treatment at a lower level of care, which could be on an outpatient basis with some medication-assisted treatment. With that being said, that would be part of the discussion, and that might trigger that go into one of our nurses or to our physicians who might say, you know what, despite the regulatory requirements, which would allow a person to go to a higher level of care, what I think people get confused about is with this regulation, they believe is, well, now I can just access these services and there's nothing preventing me from getting treated and then getting the services paid for. What I don't think they understand on the back end, where the payer has some ability to make some changes, is they could always, on a retrospective basis, do what is known as a medical review of that individual. And if they found out that that person was really going inpatient when they really did not meet the requirements of the medical necessity to go to inpatient, those services could be said denied. So that's why it's really critical that that information that comes from intake is really given to, appropriate and shared, and they can help them determine what may be the most appropriate. I think that people get confused. They say, well, I'm just going to go to inpatient. Well, it's not like you're going to a hotel. You're going there to get treatment. And if a person does not need to be, again, treated in a higher level of care, it may be appropriate to go to a lower level of care.
So here's, and that triggered for me a term that we use, but I think the audience, it's good to know what it means. So that way, a loving family member trying to refer somebody in, or yourself trying to get yourself into treatment, the term medical necessity comes up. And that simply means that does that person require, as you said, that level of care?
Correct.
Meaning he or she needs this because this has happened, this has happened, this has happened, this has happened. If those pieces aren't there, then they don't meet medical necessity, right?
Correct.
And so they would go to a different level.
Correct. And I think that's really important. I mean, one of the things that I would always tell a consumer to try to do is, go to a reputable facility. I think, what happened, again, when I started here in 2017, and actually I actually give credit to the search engine Google for doing what they did, was a lot of agencies, would post their names up in a Google search, and I think that parents, and particularly mothers, because they seem to be the ones that, for the most part, look and try to do the most research on behalf of their loved ones, think they're doing the best thing right by them, and they'll look and they'll see a name, and if they see a name show up first in that search engine, they immediately assume, well, that's the best facility. And I think that's where the challenges come in. So I think one thing that I would strongly encourage an individual to do is to work with their insurance company, who might be able to help redirect them. they do a number of the insurance companies do tier facilities, and by tiering facilities, they actually have a ranking system they put into place to determine who might be performing better in certain measurements that would be more advantageous to a consumer to decide which place to go to.
Okay, so just by Googling, that's not going to necessarily get you the right place.
Correct.
Or a good place.
Correct.
Because they can simply advertise that.
Correct.
But your insurance then can help guide you looking for the right place to fit you the best, correct?
Correct, and then one will be looking in the next year. There is a formal agency called Shatterproof, which is starting in 5 states. It's going to be piloted, and I believe, if I have this correctly, I believe it's in Massachusetts, Connecticut, New York, West Virginia, and Louisiana. Those are the 5 states that Shatterproof is starting an initiative in, which is taking key metrics that they're going to be utilizing to help really be able to truly rank a substance abuse program. So if you think about in the old days, and I know I'm aging myself here, when people would purchase a car or a television set, they might use what is known as consumer reports. And you would look at what consumer reports did, and they had certain elements that they would try to rank a facility or an entity to see who's doing performance. That's really what this Shatterproof is going to do. So it will give the consumer a really better understanding who is really not just preferred, but who's really doing the best in sense of getting the best outcomes for these clients. Because as we know, of this particular population, it's extremely challenging, where there is a very high level of, unfortunately, clients not able to maintain the sobriety, so you'll see them go over and over again. You want to see what the various agencies might be doing to hopefully stop that, or to have what we call positive outcomes.
Okay. Okay, so this is, I think, very valuable for our listeners and viewers. Let me throw some scenarios out, and I'm sure you've seen them, probably even all kinds of others. I'm a mother. I want to get my daughter into rehab, as she says, rehab. Okay, and why? Well, because she's been using a lot of pot, and on occasion at parties cocaine, and occasionally she'll drink a lot of beers at a party. Just based on that, not knowing anything else, where might she be best fit for level of care?
Right. Well, I think, right away when you hit the first thing, which is cannabis, as we all know, in Massachusetts as well as in a number of states, cannabis is now legal. Like
alcohol.
Right, legal drugs. So, and as we, for those, and again, people may not be cognizant of this, but there is no treatment protocol for cannabis. So if any...
No detox, for
right,
sure.
So if anybody is looking online and does a search where there's an agency that's saying they can treat cannabis, right away that should automatically be a red flag to you saying, I don't want to go to this facility.
They are not reputable.
Right, because there is no treatment protocol. With that being said, they did note potentially cocaine and alcohol. And then, again, I being a non-clinician, I don't want to go outside my lane and comfort. But certainly one of the questions would be, is a person who does binge drinking and is not doing it, frequently, it might be just a weekend.
Right.
Based upon at least the kind of things that you're known in the elements, they probably would not be appropriate for that, again, as knowing that higher level of care, and they might be something that could be treated strictly on an outpatient basis and have said discussions with a therapist. Because usually, and again, in a number of cases, a person who does cocaine or a person who has regularly drinks, there's usually some kind of underlying behavioral health scenario that has triggered these things. And I think that's what really needs to be the root cause to be treated. And in a lot of cases, that does not require a person going to a detox or to a residential.
So let's say they go into outpatient.
Yep.
The outpatient clinician there starts assessing and listening and all of that and says, you're right, there's other stuff going on. Yes, we can tackle what you're doing with substances, but we can also work on the other stuff or make a referral for a different level.
Correct.
Right? Okay. So it's not only working just with insurance, it's also understanding and working with the treatment provider, let's say Spectrum, let's say New England Recovery Center, right?
Correct. Yeah, I think that's very important. I think, again, one of the challenges, and again, I'm going to take off my Spectrum hat and put on my old hat from the payer side. One of the things that we used to find out is, in a number of cases, clients may not always be 100% upfront with their treating provider. And the example I would say is when I worked for a certain payer, they used to have a client up front. Basically, it was a 20-question questionnaire that they would complete, and it would be done in various intervals within that person's treatment, and it was only on the outpatient side. And what we found out was usually it was done between the first session and again the fifth session and thereafter. And on the first session, you may ask them questions like, do you have a substance abuse issue? And they'll say, no, they don't. And yet on the questionnaire where they're actually not talking to you face to face, trying to build a trust, when the same question is written down, do you have a drinking problem? And they say yes, or they might say, how many drinks do you have a day? And if they put down 10 or 12, that would kind of trigger saying, oh my God, this person probably does have a substance issue. Yet when they verbalize it, they haven't done that. So what we found out in our study was in a lot of cases, a patient has yet to build the trust with the treating provider, yet when they put the stuff down in writing, they actually say something different. And that's why it was a very interesting instrument to use, because we could then, we would not be just totally relying on the person saying stuff. We could see what they put down in writing, and that would help us raise questions into discussions. You know, one of the things that we found out, and again, it was very interesting with the provider community, was a lot of times providers were very uncomfortable as it relates to asking them questions about drugs and alcohol, and they would avoid those questions, yet you would see them noting it on the form, which was an irony, and that helped us in getting people into the appropriate treatment.
And that's very interesting. I can only imagine now for viewers who had to go through the system trying to get somebody in themselves into treatment and all of that, there are hurdles, obstacles. Some of it that we just discussed is, you know, not understanding what level of care means, where you are eligible for based on your symptoms of what's going on. But then the other hurdle is sometimes client themselves, because they're scared perhaps or something else, that they may not be completely open about what's going on. And that happens, and that's part of what they're going through.
Right. I think the other thing that, you know, again, I think in Massachusetts, and again, you know, your audience, I'm assuming, is primarily in Massachusetts, but you may have other states as well. Obviously, when Chapter 258, which is a regulation that came into place in 2015, it eliminated some of the barriers that clients may have had previously in accessing substance abuse services, at least the higher levels of care, where before they had to get a prior authorization for access to these services, and the payer could deny it, saying you don't need this level of care, you can have another level of care. Nowadays, based upon this law that went into place in 2015, October 2015, a client can upfront automatically get 14 days of a detox or residential or lower level care without any prior notification, although we always used to encourage people to notify for the purpose of claims payment. Where these challenges come in, though, I'll use a different example, would be a client with an eating disorder. There's a perfect example where a client a lot of times may ask to access services. And what I know in working in the payer industry was they would have certain algorithms that a client would need to meet in order to get that high level of care. Most of it was really weight size and BMI, which if they didn't hit a certain things, they would be denied. And I always found that very frustrating. And what the client used to struggle with, well, what else could I do to try to access these services? Now, the first thing they can always do, which I don't think a lot of times clients know, and I think that, again, I'm talking to your consumers, is that in Massachusetts, as well as in most states, a client always had what is known as an appeals process. And in Massachusetts, you actually have 2 levels of appeal. So a person can appeal and ask for a re-review of the clinical information. And usually in that situation, the treating provider is actually an advocate for you. They're actually providing more information to share with the insurance company, who would have that ability to still say yay or nay. And in Massachusetts, a denial can only be done by a physician. It can't be done by another level of care, another clinician.
So a nurse cannot deny
nope, it has to be done by a
clinician cannot.
Nope, a physician always has to deny in Massachusetts for a higher level care. Now, with that being said, that can be the first, and then it goes to a second level. What people don't realize in Massachusetts, even after you've gone that far and you still have been denied, you still have another place to go. And that's why I always tell people in Massachusetts, and I found out I had done a similar podcast at another event, and I found that they have this similar program also in Colorado. In Massachusetts, this is a advocate for you called the Office of Patient Protection, otherwise known as OPP. And a lot of people don't realize that exists, and that is actually...
So how can they access that?
So they actually just go and they can contact their insurance company, who will share that information, and it's an advocacy group that actually supports member and potentially providers, but more member, to get access to services where they might be denied. And the one thing that I will tell you is kind of a little trick to the trade, is that most of the payers when they see and they get, if a person makes a complaint, it goes to the Office of Patient Protection. The Office of Patient Protection, believe it or not, is actually their own little group of people, and they do hire clinicians who will be the final decision makers either to approve or deny. So they become the final state. So they can overturn the insurance company. And if a person tends to go to OPP, in a lot of cases, depending upon what services are being requested, and I can tell you there's two in particular. If a person has an eating disorder, and if it's a child or an adolescent for which they look for usually a higher level of care, usually when the payer sees and that information comes, it's now reached that level, which means it's usually a formal letter that's going to be written where they'll be able to have that discussion with the insurance company. 9 times out of 10, it might even be higher, the insurance company will automatically upfront overturn themselves and actually approve it. And there's 2 reasons for that. One, there's a very high percentage of overturns that OPP do with those 2 populations. And B, which I don't think people realize, whenever it goes to OPP, there's an added cost that the insurance payer has to pay.
So they don't want to lose that.
They don't want to lose it. And they're also stuck continuing to cover those days until that case is heard.
So let me throw you a monkey wrench. Okay, a person who has a diagnosed eating disorder, and let's throw, which this happens a lot,
correct,
a substance use disorder on top of it. What happens here?
So that's a really good one. As a matter of fact, it's very common what we find out that there's in comorbid conditions, people who are not going to use the eating disorder, who may be trying to maintain their weight. It's not uncommon for them to be snorting cocaine at the same time, which helps them do that. They would, depending upon the service and depending upon at that point where the patient may meet their medical necessity needs, it's very possible they may start off in a detox and then be eventually transferred over to an inpatient program within the eating disorder, or it could be vice versa. One of the things.
But I'm confused. Why would they go to a detox if it's just cocaine? Because there's no detox.
I'm sorry, I apologize. You're right, I apologize for that. So in that situation, that's a really good one. So use cocaine, which is a good example. And I think he wasn't listening, so I heard it myself, is that the person in that situation would go to the eating disorder, get treated for the eating disorder, and then simultaneously would be, and again, we've developed relationships, I know, at Spectrum with various eating disorder programs. One in particular, we've done some work with Walden, where the client will actually be driven daily to get some kind of medication-assisted treatment. So they'll be treated by us on the outpatient side, simultaneously getting their treatment on the inpatient side.
Now that's significant because a lot of places don't do that,
right,
don't work with. So I mean, kudos to folks like yourself and others who have created these networks that our clients can access through Spectrum or New England Recovery Center.
Right. I think it's important that one, I think, again, not knowing this industry fully, but building collaborative relationships. Well, what you're really trying to do is the best thing for the member. I think that, I always hear these horror stories where a person starts off at a, it might be more, I use the example of, say, a psychiatric issue. They'll start off an inpatient program, say, for the eating disorder, and they'll go there for a week, and then they get discharged, and they go for a week for their mental health inpatient service. You really should, the hope is you should be able to get all your treatment done in one area. That's why, I think one of our missions that our CEO is providing here is that when people think of Spectrum and New England Recovery Center, they think of it as primarily a substance abuse focused organization. And I know our CEO is really trying to change the dynamic where we're really seen as more of a behavioral health organization. So we're really treating all of it. So the person, and as we noted earlier, most people who have a substance abuse issue usually have some kind of underlying mental health issue that is the root cause that's creating. I think we can treat both of them within the same program.
So here you go. So we've been around Spectrum for 50 years. We just
Correct.
Celebrated that. And yes, 50 years ago, we didn't have it was mostly substance use that we were doing. Now, we are integrating more and more into behavioral health, as you said. Okay, so now, let's say person calls, oh my God, my husband, he needs help. He's an IV user of heroin. He drinks as well, sometimes a lot, sometimes not as much, but it's the heroin. He does have depression, diagnosed with depression. He also has a blood disorder.
So there's some medical complexity.
Medical stuff, because that happens with folks
Correct.
Who come in or are asking for help. So what happens
So
here?
that's a really good example where, depending upon the severity of one's medical position, we as an organization would want to have those full conversations. That would probably that definitely would be something that would be reviewed then by our medical team, either both the nurses and probably our physician.
During the intake
During
process?
the intake process, right. And then based upon that, they would make a determination if a substance abuse program like us is an appropriate level of care, and it goes back to that terminology before for a place like this. And I think one thing the audience, may need to understand that as it relates to substance abuse, there's different types of substance abuse programs. And again, I know this is, jargon that we utilize that's going to be very difficult for the standard consumer to understand, but there's different levels of detoxes. There's a detox 4.0, which is that highest level, which really is that medically monitored complex program.
And that's the only one that's close by is AdCare.
Is AdCare, or it would be a general acute care hospital, so like a UMass or a Marlboro hospital. In theory, they could treat a person at that level, and with those potential other conditions, they may need that higher level of care. And really what it really is the major difference is that you have a physician who's really on staff 24/7 versus just nursing. That's really the primary difference.
And they can do IVs and all of
and
that,
they have the ability
should
to
the
do that.
person need it.
Right, and I would say another one that we hear a lot of is, people if they, had some kind of, situation where they might have had things where they require like a medication called Coumadin, which is for blood thinners. Those would be something that a place like us, or what is called a Detox 3.7, would be something that a facility like wouldn't be able to handle that, nor should they. You want to put a patient in a place where all those conditions could be treated and handled.
Like you said, the appropriate level of care.
Correct. And again, that's why it's critical, again, when a person is looking, into, again, from a standpoint of educating themselves. And I really think it's important, when, it's interesting, which I always find in shock, when people buy a car, it's amazing how much research they'll do online. But when people want to go to a doctor or to a hospital, how few people do that upfront research to determine who's good and who's bad. There really is a lot of information out there. And again, I wouldn't be always dependent upon, Google, because again, a lot of that information, I'm not saying it's not accurate, but if people look and say at the first page, the average consumer may not even know that a person, if the paid ads are the ones that are going to always show up first, it doesn't mean that it's the better facility. That's where I do think you would, despite, I know people are always having stigma as it relates around substance abuse, but if people really want to get treatment, contacting one's insurance company, they really want to work with you, and they have a whole bunch of information that really can help redirect you to what place might be most appropriate for your family
So let's
member.
jump then. I have Mass Health. Do I call Mass Health and they would help me? Direct me to where
Mass
I should
Health
go?
could be, there's certainly the BSAS website, which is the Bureau of Substance Use Services. They, in a lot of cases, people who have Mass Health have it through different health plans, so they could have a tough Mass
But you
Health
call
product.
that 1-800 number, whatever it is.
Yeah, and they could try to assist you, redirect you. With Mass Health, there are a few other differences that people need to be cognizant of. One thing that is really critical with the Mass Health population is that it's critical, and DPH makes it a requirement. There must be that conversation with that said person who's requiring the treatment. That more information that comes from that.
They have to talk directly.
Correct.
Can't be mom calling on behalf.
Right, and even and for that sake, we actually do also, for the most part, require that even with the commercial population. But I mean, there are always potential opportunities where we might. But for the Mass Health, that is a requirement. And I would say, one of the bigger challenges which is unfortunate, is a lot of times, despite the state making significant, I want to say increments as it relates to revenue for substance abuse, despite that, and there still is unfortunately a very limited number of beds that are available to clients who need those services, and it really comes down to the reimbursement doesn't compensate appropriately
At the state level for
Correct.
Mass Health.
Right. Yeah. With that being said, and that's why again, I'll take the opportunity again to kind of build upon some of the things of Spectrum. We were in this industry for 50 years, and we were primarily a Mass Health
And
focused
it's our
provider.
mission still.
Correct. And that's the last thing you would ever want to say to a client or to a client's loved one is that, we can't take you for our beds are full. So we really do everything that we can. And in some cases, and I'm probably going to get yelled at when this gets sent out by our CEO and COO, but in some cases, we've actually held clients overnight in one of our commercial beds just so we can get them into treatment so they can then go to the Mass Health bed when it becomes available, because we don't want to say no.
But to quote our CEO, it's the right thing to do.
You know what? And that's the big key. And I think that's one of the things that was very alluring to me coming from the payer side, that I felt that I was actually working for an organization that was doing what I want to say is the right thing. And I think that that's really the most important thing. At the end of the day, I know that I can go to bed and sleep and feel good about what I'm doing because I know how I'm affecting people in a positive way. That's not something I always got on the payer side.
And that's, again, because we're a nonprofit, Spectrum Health Systems, for instance, there are for-profits out there, and they're looking at, quote, their bottom line above anything else. They probably wouldn't put up somebody like that, like we would,
Correct.
Because it's the right thing to do
Right.
from a clinical, humane perspective.
But I wouldn't want to create a myth that, because again, when I was in graduate school, I do remember that when they think of the term not-for-profit and for-profit, the term not-for-profit doesn't mean that you don't make money. It just means that the way one uses their money...
It goes back into the services.
Correct. And I think that's a big deal because, both organizations, obviously, if you don't make money, you go out of business.
Right.
But just the way they're using. So I think that, you can be a for-profit organization and still be a nice and good organization.
Sure
but I do understand the level you're coming from. And I think that as a consumer, one of the things that people need to look at when and again, the opioid epidemic is obviously still something that's happening and it's gone now. It's hard to believe it's been several years now. It's allowed an opportunity for new entities to come into this market. And I do think, and I think this is really what we're trying to hit upon, is that a lot of the people that have come into this market may not have come in with the same mission or the reason for why they came into the market. They came into this market because they see this as potentially a profitable opportunity versus a place like us that came into this market because, again, it was the right thing to do into treating this population, providing badly needed services for a population that has not been provided adequate treatment.
Right, because our folks struggle a lot. And
Correct.
That's unfortunate for them. But at least we're doing the right thing. It's the right thing to do.
Correct.
So now let's go to some more tricks of the trade. Distraught family member, wife, trying to get their loved one in. Who should they call first? Should they call directly, looking on Google and call, we have a 1-800 number, correct?
We do. We have a vanity line.
Yep. And call that number. What would happen? Should they call that number first? Should they call their insurance? Does it matter, Mass Health or Tufts or Blue Cross?
I get asked that question a lot.
That's what I'm asking you here.
And I don't always think there's one answer. I think a lot of times in this industry, a lot of the time clients, it's really word of mouth. It's amazing, if you have a positive outcome and a family member gives you a positive testimonial, how far that can go in getting future clients in. And if you have a negative outcome, how negative that could really impact you.
Word of mouth.
Word of mouth. But, in a lot of cases, you can use search engines. I do think, working with the payers is not a bad way to go, but working with the insurance companies. In a lot of cases, which people, I know they're afraid because of the stigma as it relates to substance abuse, working with your human resource department is not always a bad thing either. They might have some really good suggestions for you. Okay. I think that, people, what makes, I think, Massachusetts a very unique state versus, say, the rest of the country, that, we've always recognized substance use of mental health really the same as medical. We don't really see that deviation, and yet if you go to other parts of the country, they really have this myth out there. People
lagging,
choose to voluntarily drink, or they voluntarily take drugs. They don't understand it's really a brain disease. So, again, I think you could work with VHR. I do think the insurance company can be beneficial. And again, one of the issues, some things may be out of their control. If a client's looking for a bed, there is, particularly as it relates to the Mass Health beds, they're very limited, they're very tight. In most cases, they're always running at 100% of a census. So you may not be able to be so choosy as to where you want to go if you want to get treatment. So that's something, there are some limitations. I think of commercial beds, there are a little bit more of an opportunity because I think it's the market due to the recent epidemic has been saturated. There was a lot more detox beds that were previously available over the last year. There was been 4 new entities that have opened up in the last 12 months. So that there is great opportunity so people can do some more research. But again, I would say, do your research. Why would you do something differently? I go back to that logic, which I can understand. When a person buys a car or a person buys a television, they do all this research using literature, consumer reports, Google, and yet when it comes to the healthcare, they do no research. It boggles one's mind. One should go and listen and talk to people. They can go look at, there's tons of advocacy groups that can try to assist you, but you really want to get your loved one into a quality place where you believe not only you're going to have good outcomes, but you believe that there'll be some kind of continuation of treatment. And again, I think one thing that, again, plugging Spectrum in the New England Recovery Center, I think that makes us unique versus, I think, a number of other agencies is we do, as you noted up front, offer what is known as a full continuum of treatment. So a person who may have a substance abuse issue with an underlying behavioral health condition may require treatment for a long period of time, even after they've left a detox or residential. You would prefer if within that same program you have other options where they can get access to services.
Right, and that person doesn't fall through the cracks then either.
Correct.
And again, for our audience is pretty educated about addictions. The idea that it's a brain disease, yep. The idea that you're going to be in recovery for the rest of your life, yep. Which means you may need care after you leave a residential program. You might go to outpatient for a few years, maybe. Don't know. But why wouldn't you want it? If your insurance is saying, I can take care of that, we'll pay for it, and they say you need it, your clinician says you would benefit from it. It's just like having heart disease. You go in for an operation, and then see you later, you're good to go. You'll live a great life after your heart operation. That doesn't happen. They set you up with dietitians, with rehab specialists. They say, stop doing this. Come in routinely for regular blood works and all that to promote your recovery from that.
Correct.
Make sense?
Yep.
And insurances will cover that.
Correct. And I think what's happening in the insurance industry, again, is, and again, this goes to where Massachusetts, I think, is far above the rest of the country, is the whole concept of the accountable care organizations, ACOs, where your health plan is now, you might have selected a medical provider group, which is part of a whole system of care. So what you're seeing is a lot of what is known as now medical behavioral integration, where in the past, for many years, the behavioral health providers and the medical providers were really siloed. They were kind of working separately and going on totally different avenues. Now they're really realizing that it's really important to bring them together, and that's why it's really called the whole care system now, where your medical provider is now really, it might even be part of a whole treatment team, where the behavioral health provider is actually working, co-located in that same office as a medical provider, and doing a lot of those treatments together. And I think you're seeing more and more of that, where there's a lot of good coordination of care. So if we're seeing somebody on an outpatient basis, we're coordinating back with their primary care physician and their medical provider.
So they're communicating.
Correct, because you want to share that information for multiple reasons. But again, I think people don't understand that behavioral health services by themselves, you really need to work together. I know there was a study done, I remember when I was working for an outside source, where France had done a study where they had found out that 70% of people who had back pain when treated for a behavioral health treatment, that found out that if they treated, in the majority of those cases, depression, they actually treated the back pain, which is kind of an irony. Who would think that depression would cause back pain? But there was, based upon the study, a linkage between the two. And what they're seeing more and more of, and substance abuse is a good example.
Somatic psychology.
Right. Well, substance abuse, you'll be infected, other parts of your body, your liver, if it's not treated. So it really is whole care.
So what's the approach that a person needs to use? Come in with aggression and call? Should they be nice? Should they be maybe a little educated, have some stuff in front of them when they call their insurance, or they call intake or something like that?
Yeah, I think, again, I think doing as much research up front is really important. But I also think they have to realize, do not see this as an adversarial relationship.
So don't come across as aggressive.
No, it's not going to work if you you want a partnership. And I always believe, something I always took away from my parents, you get a little bit more of a little bit of sugar than,
I believe that too.
And if you treat people kindly and nice, they tend to be much more responsive to your needs. That doesn't excuse a person, if they're not nice, not to be responsive.
Sure.
But it certainly helps. And again, if you call organizations, and we use Spectrum in the Recovery Center, we may not always be the most appropriate place. But what we will do on our end, and again, any reputable substance use facility would do, is if we are not that place, we will help identify a place or a program that would be most appropriate. We wouldn't just let a person go by the wayside and say, we're done.
No,
and I think that's really critical.
That wouldn't be the right thing to do.
Right, and I think that's important, because again, I think using your line, it's the right thing to do.
So, well, that's our CEO's line, not mine. I can't take credit. So, in a minute, what is a good takeaway for our viewers, because we're coming to an end here?
I would just say, again, for the average consumer, I think it's really important that one does research and think of like anything else they would purchase. It's a very important component. I know the intent is always doing the right thing by the loved ones. I would think that in a lot of cases, working with your insurance company can be very helpful. Again, do the research. And then, don't always just assume because a person or an entity is automatically in a search ranked the #1 facility, that automatically means that that's the best program to go to. There's a lot of algorithms that are in systems which allow entities to get ranked. It doesn't mean that automatically assumes that they're the best. So again, do your research like you would do for anything else you would purchase. If it's really your loved one, you should do that. And always feel free to call your insurance company. You can call a provider, and they should, if they're truly a reputable provider, they will assist you because that is, again, the right thing.
And what's our 800 number?
800 number is 877-MY-REHAB. So it's a really easy tagline to remember. Call that number. What makes us unique is we are available 24/7, so you won't be getting an unanswered call. We will be able to assist you then and there, and we can provide you with appropriate information at that point. And that means if you need to come in the evening, early in the morning, we can take you in and handle that accordingly.
Perfect. Thank you, David, for being our guest. Hopefully we can have you in the future again with some new stuff if
Love
necessary.
it. Well, thank you.
And thank you, audience, for watching. I say this is Airing Addiction. Again, host Dr. Romas Buivydas. We will see you next time. Take care.